Bladder tumors are more like becoming more in number, and the bladder biopsies are like 10% of the daily workload. So I thought I will talk about how to approach uh, the bladder tumors. And let us start with the bladder histology, because histology is very, very important to understand the uh, pathology and WHO classification. So we will go through the WHO classification, which is the 5th edition in 2022. And then let us see a series of cases, and I will try to tell you how to approach after seeing the cases. We will go through what are the important IHC markers in bladder pathology. And without molecular features, any pathology talk is very incomplete now, because we are heading towards targeted therapy. And for that, molecular features are very, very important to understand and to help the patient and the clinicians. I thought I will start with a pre-test and post-test. These are 5 questions. You can just note down in a paper, and same questions will be repeated after the presentation, and you should be able to score more. That's the idea. But after some of my presentations, they do bad in post-test. That reflects my teaching. And I will end it up with the conclusion and references. And whenever I want to take you notes or a picture of that, I will put this sign where you can. Madam, can you see my arrow, madam?
Yes, sir. Yes, sir.
So, thank you, madam. So, whenever you see this image, that means you can take a screenshot of that. And let us proceed. So pre-test, copying is strictly allowed if you are sitting together, but make sure the other person is telling the or putting the right answer. Only one response is positive. In the normal bladder mucosa, the following cells can show atypia: smooth muscle of muscularis propria, endothelial cells in the lamina propria, basal cells, umbrella cells. Just select one response. Question number 2, neutrophils and lymphocytes are commonly seen infiltrating the bladder mucosa in A. Reactive atypia, B. Low-grade dysplasia, C. Carcinoma in situ, D. Infiltrating carcinoma. Very frequent mitosis seen in papilloma, lump, or papillary urothelial neoplasm of low malignant potential, low-grade papillary urothelial carcinoma, and high-grade papillary urothelial carcinoma. Urinary bladder cancer can be caused by beta-naphthalamine, tobacco smoking, schistosomiasis, all of the above. Lymphovascular invasion is high in the following variant of bladder carcinoma: squamous cell carcinoma, micropapillary carcinoma, adenocarcinoma, plasmacytoid urothelial carcinoma. So these are the 5 pre-test MCQs, and let us jump into normal histology now. The bladder is lined by a specific type of epithelium that prevents the urine coming into the blood, mixing with the blood, and that is called urine-blood barrier. We all know blood-brain barrier, but urine-blood barrier is also important, and that's made by urothelial cells. They are of varying thickness. Previously, they are called transitional, because depending upon the status of the bladder, they take different shapes. When the bladder is full, they will be flat. When the bladder is empty, they will be columnar. That's why it is called transitional, and you all must be knowing it is called transitional carcinoma, but now we don't use that. It's this property of epithelium changing the size and shape is present only in the bladder and related structures, and so these are now known as urothelium. So it's a urothelial carcinoma. When somebody reports as transitional cell carcinoma, that means they are not updated. So never use transitional, it is urothelial. And these urothelial cells are covered by large flat cells that cover more than 2 or 3 cells underneath. That's why they are called as umbrella cells. And these umbrella cells can have atypia. So when you see atypia in these umbrella cells, don't pay much attention or don't think of dysplasia or carcinoma if atypia is seen in the umbrella cells. And coming to these cells, these are, as I told you, they may be cuboidal, columnar, or flat, and the nuclei are running in one direction. They maintain the polarity. They are of uniform size, shape, distribution. There won't be any overlapping. That is very, very important. Whenever you see overlapping or variation in size and shape or loss of polarity, sorry, loss of polarity, we have to think of pathology. And what do you mean by polarity? For people who are listening to my lecture first time, I'm telling this because I used to tell this in all my lectures. Draw a line along the long axis of the nuclei, and all those lines will be parallel to each other. That means all the nuclei are traveling in one direction. The very important thing is to know the polarity. The nuclei has to be oval. If it is round, we don't know which is the long axis. So for when you see round cell lesions, you should not talk about polarity. Polarity, we have to talk only when the nuclei are elongated or elliptical. I hope you all understand. And this is the normal urothelium. Coming to WHO classification, 5th edition Blue Book 2022, mainly the urinary tract tumors are divided into primary and secondary. In the primary, it is urothelial and non-urothelial. In the urothelial, it can be papillary or flat, non-invasive or invasive. And non-urothelial, it can be squamous cell carcinoma, glandular carcinoma, urachal and diverticular lesions, and Mullerian lesions. And non-invasive papillary urothelial lesions are 4 of them are there. Papilloma, papillary urothelial neoplasm of low malignant potential, low-grade papillary urothelial carcinoma, and high-grade papillary urothelial carcinoma. The flat lesions, atypical urothelial proliferation, atypia of uncertain significance, dysplasia, and carcinoma in situ. In the invasive component, it's a classic with divergent differentiation. And whenever you see divergent differentiation, you please mention the percentage. For example, you see urothelial carcinoma with focal squamous differentiation. So you mention urothelial carcinoma 80%, squamous cell differentiation 20%. Because the percentage of the divergent differentiation also helps us to talk about prognosis. And there are various types are there in urothelial carcinoma. To name them, they are nested, tubular microcystic, micropapillary, lymphoepithelioma-like, plasmacytoid, signet cell or diffuse carcinoma, poorly differentiated carcinoma, giant cell carcinoma, sarcomatoid carcinoma, and trophoblastic differentiation. Coming to the non-urothelial, the squamous lesions may be papilloma, verrucous carcinoma, or squamous cell carcinoma. The glandular lesions are villous adenoma and adenocarcinoma. Adenocarcinoma can be NOS, enteric type, mucinous type, or mixed type. Urachal and diverticular, they are very important. Carcinoma can develop, so they are named as urachal carcinoma and diverticular carcinoma. In the Mullerian origin, we have 2 of them, clear cell carcinoma and endometrioid carcinoma of the bladder. So these are all the WHO classification. Take a note of this. Now we are going to see cases from 1 to 12. Case number 1, 69-year-old male hematuria. This is a cystectomy specimen. You can see the papillary process. So whenever you see a bladder lesion, you have to see whether it is papillary or flat. And you can see nice papillae here with the fibrovascular core. This fibrovascular core is very, very important. And see the epithelium, there is mild atypia, okay? And the nuclei are crowded in areas, but there is no anisopoikilocytosis, what we say in peripheral smear. There is no variation in size and shape of the nuclei. They are more or less uniform with mild crowding and atypia. So this is a non-invasive low-grade papillary urothelial carcinoma. Each word is important. Non-invasive, very, very important, because treatment difference is there. We will talk about it. Low grade, any urothelial carcinoma, we have to classify them into low grade or high grade, papillary or flat, and the urothelial carcinoma. So non-invasive, low grade, papillary urothelial carcinoma. Case number 2, this is a endophytic lesion. What you saw in the previous case, that's a exophytic. Here, this is the bladder lining, urothelium, and the lesion is beneath the epithelium, and it looks like a trabecular papillary arrangement, but it is inverted. And these cells more or less look like the cells we saw in the previous case, first case. So this is a inverted papilloma. Case number 3, 52-year-old female with hematuria. Cystoscopy showed a polypoid lesion. Here you can see necrosis and papillary process, but this is a very broad papillary process. When you compare the papillary process of the low grade, they are very delicate, whereas here it is broad and irregular. And you can see a lot of nuclear atypia and pleomorphism. Again, the criteria for pleomorphism, those people who are attending first time, we have to have criteria for everything. Criteria means when are you calling, going to call pleomorphism? When are you going to call loss of polarity? Loss of polarity I already explained. And this pleomorphism is take the smallest cell and the largest cell. The largest cell should be 4 times the size of the smallest cell. That is the criteria for pleomorphism. And frequent mitosis, this low power, it's very difficult to appreciate them, but you can see the necrosis and a lot of pleomorphic nuclei there. So this is a non-invasive high-grade papillary urothelial carcinoma. And you can see how the papillary processes are fused together. And see the atypia and see the loss of polarity. Take this cell. This cell is running like this. This cell is running like this. This cell is running flat like this. So there is loss of polarity and the nuclear pleomorphism. The smallest cell is this one and the largest cell here more than 3 times or 4. More than 3 means 4 times. Okay. So, and it will show frequent mitosis. When you are looking for mitosis, it is low grade. When the mitosis is looking at you, it is high grade. So that's a high grade. Case number 4, 65-year-old male with hematuria. Here, what we saw in the previous 3 cases are papillary processes we can appreciate, whereas here it is a flat lesion, and they show nuclear pleomorphism. And this atypia is seen from the lowermost cell to the uppermost cell, and you can appreciate the loss of polarity here. See, this cell is running in this direction, this cell is running in this direction. So this cell is running in this direction, this cell is running in this direction. So they are running in different directions. And another example I say, when the polarity is maintained, it is like traffic in the national highways. When the polarity is lost, it is like traffic in front of you, any medical colleges, because all the directions, the vehicles will be coming into the medical colleges. So there is a loss of polarity, nuclear atypia and pleomorphism, and that atypia is in through and through the thickness of the urothelium. So this is a carcinoma in situ. So loss of nuclear polarity and irregular crowding. Sometimes here this case is very crystal clear and you can see frequent mitosis there. Sometimes there may be a question whether it is reactive ATPR. For example, we will be seeing them in future slides. There will be a lot of neutrophilic and lymphocytic infiltrate. So you know whether it is you don't know whether it is reactive or dysplastic. In those conditions, cytokeratin 20. In dysplastic epithelium, all the cells will take the cytokeratin CK20. Whereas in reactive ATPR, only few cells or scattered cells will be positive. P53 will be mutant in dysplasia. It's more than 80% of the cells are positive, and Ki67 again will show lot of reactivity because this is dysplastic. Whereas in reactive, P53 will be wild type or normal, Ki67 will be very low. So these IHCs, we will be talking about it again. They help in flat lesions, whether it is reactive or dysplastic.